for joining us for this Lunch and Learn on the new release of the Diabetes Canada Clinical Practice Guidelines. So these, I think a few of you have probably tuned into some of the earlier sessions that Dr. Phillips has held. Our speaker today is Dr. Richard Phillips. He's an adult endocrinologist that works here out of Kelowna, recently joined Interior Health just under a year ago, and is also our Health Authority medical lead for diabetes. So happy to have him presenting on highlights of the new clinical practice guidelines, looking today at the chapters around pharmacological management of diabetes care. So thank you very much. Just a reminder before we pass over the ball to Dr. Phillips to start the presentation, please do keep your lines on mute, *6, until we open up at the end for discussion and question opportunity, at which time you can #6 to ask questions. So that'll just kind of keep down any feedback we have as we go through the presentation. And just a reminder that we are recording this session, so when we do open up for questions, just do be aware of that. So thank you, and I'll pass the ball to Dr. Phillips to carry on with the presentation.
Very much, Angelina. Hopefully I won't drop the ball. The initial plan was to review 3 chapters. I neglected to send over the slides for the complementary therapies for diabetes, the alternative and complementary therapies. There was only one slide as part of that, actually. And just to briefly that Diabetes Canada says that there are insufficient studies of sufficient rigor to recommend any particular alternative or complementary therapy. The substance of the chapter does describe a number of complementary therapies, whether it be traditional Chinese medicine or certain herbal type preparations that in very small studies have shown a small decrease in hemoglobin A1C, for example, but the evidence isn't sufficient for Diabetes Canada to endorse any of those particular approaches at this time. So that was what that slide said. And I don't know enough about those particular therapies to say anything above and beyond that. So if anybody has any questions about it, then we can address it later. The pharmacological management of type 2 diabetes and type 1, I think the guidelines are helpful compared to previous iterations in the sense that I think they're a little more prescriptive than they used to be. And I think this is helpful for our primary care physician colleagues out there, because I must admit the pharmacological landscape for both type 1 and type 2 is potentially very confusing. And with so many tools in the toolbox, the question is to, which medication and in what combination is the most appropriate for the patient sitting in front of you can be a bit of a challenge. And I think these guidelines, by being a bit more prescriptive than they have been in the past, can be helpful. So moving right along, the pharmacotherapy type 2 checklist. Choose initial therapy based on what the blood sugars are looking like. So clearly patients with severe hyperglycemia who are catabolic with weight loss, polyuria, polydipsia, and high sugars would be suited to be on insulin right off the bat. For all other patients, of course, after addressing diet, exercise, and weight loss and general diabetes education, the drug of first choice is considered metformin, as long as no contraindications and as long as the patient can tolerate it. Anything above and beyond that, we'll talk a little bit more about individualizing therapy based on specific patient characteristics and trying to reach targets within a reasonable period of time and not falling for the so-called therapeutic inertia of being on high blood sugars for a long period of time. Initial choice of therapy will depend partly on what the hemoglobin A1C is, and the recommendation is to, when you diagnose somebody with diabetes type 2, is to assess what their target hemoglobin A1C should be. So if you have a middle-aged person who has a long life expectancy, very few comorbidities, then for those people you'll be aiming for an A1C of 7% or less. If you have a young woman who happens to have type 2 diabetes, potentially in the setting of polycystic ovarian syndrome, who is thinking of getting pregnant, then your target is actually 6.5% or less. If you have somebody who's in the early 80s who has new diagnosis diabetes and they have multiple comorbidities, potentially some cognitive dysfunction, multiple indicators of frailty, their A1C may be 8.5% as your target. So the initial therapy will take the target into account initially, and if they're a little over target, then you'll be doing lifestyle and metformin. If they're a lot over target, consider combination therapy and or insulin. Telling you there. So we've already mentioned the metabolic decompensation. I think I saw a fellow today, in fact, he was in his late 40s. He was diagnosed with diabetes several years ago. He was 165 pounds usually. He went down to 145 pounds, symptomatically hyperglycemic, weight loss, blood sugars around 20. He was treated as a type 2 diabetic. He has no family history of type 2 diabetes. He was on oral agents for a number of years, then got switched to premix insulin twice a day, and has only been put on appropriate therapy with basal bolus insulin within the last couple of months, and it's only now that he's starting to feel well. So clearly in that particular fella, the initial choice of therapy would have been insulin, and he did get the right therapy right off the get-go. Unfortunately, he's developed significant diabetic nephropathy that likely could have been alleviated if he was on the right therapy from the beginning. So not always done right, but that's what we're aiming for. So this is a complicated slide, but it's not that difficult, really. Of course, the initial assessment, I still see people that are diagnosed with diabetes and they don't get sent to their local diabetes clinic. I think that's very important. They need to learn about their condition. Self-management depends on people learning about their own condition. Speaking to a diabetes nurse educator, speaking to a registered dietitian to learn the tools that they will need for self-management. So that goes without saying. Here we go. If the A1C is mildly elevated, start with metformin, and if the sugars are over 1.5% above target, consider combination therapy of metformin and a second agent, insulin if they're catabolic. Now, if they're not meeting their targets after a reasonable period of time, 3 to 6 months, and you're looking for adding a second agent, this is where the guidelines are more prescriptive. So if there is evidence for clinical cardiovascular disease, previous history of ischemic stroke, coronary artery disease, peripheral vascular disease, they say that you should consider as your drug of second choice either empagliflozin or Victoza or empagliflozin. So Jardiance, Victoza, or Invokana, with different grades of evidence with each of those agents based on the studies. And for the simple reason that the EMPA-REG study showed a reduction in adverse cardiovascular events in folks, as well as lowering blood sugars without causing hypoglycemia. Victoza, same thing, reduced cardiovascular events, reduced cardiovascular mortality without causing hypoglycemia and associated with weight loss. The CANVAS study with canagliflozin showed a reduction in 3-point MACE, so-called MACE, for adverse cardiovascular events. It got grade C, level 2, to the nature of the study methodology, as well as the fact that it did not show a reduction in cardiovascular mortality. This particular study got a lot of press because it was associated with an increase, a doubling of amputations, so that is something we can talk about later. Clearly, you need to be cautious in using the SGLT2 inhibitors in patients with a history of peripheral vascular disease or a previous minor amputation. I think this is helpful woman not meeting targets, established cardiovascular disease, we should strongly be thinking about using an SGLT2 inhibitor or a GLP-1 receptor agonist as the drug of second choice, if the patient can afford it, of course. And if the patient does not have cardiovascular disease, then they're being a little bit more prescriptive than they have been in the past as well. They're saying that we should be choosing agents, ideally, that do cause hypoglycemia and are not associated with weight gain. So those classes are the previously mentioned SGLT2 inhibitor and the GLP-1 receptor agonist, but also include a DPP-4 inhibitor. DPP-4 inhibitors are not the drug of second choice if you have cardiovascular disease, because there was no evidence for cardiovascular benefit with the DPP-4 inhibitors. They were considered cardiovascular neutral, so not increasing or decreasing events in the major cardiovascular safety studies that were done with the various agents, with the one proviso that saxagliptin was associated with an increased rate of hospitalization for heart failure. So Onglyza or saxagliptin needs to be used with caution in patients with a history of heart failure. If the patient does establish cardiovascular disease at baseline, those are the three drug classes that are currently recommended. If can't afford the DPP-4 inhibitor or the other agents, then you need to use an inexpensive medication like a sulfonylurea. The endocrinologist's self of choice would be gliclazide over glyburide due to a reduced rate of hypoglycemia. So this is blasting through the various recommendations we've mentioned. Healthy behavior interventions should be initiated at diagnosis, recognizing that if people are successful at significant weight loss and significant changes in lifestyle factors, that may be enough, and some of these folks may, in fact, be put to remission of their diabetes if this is addressed early in their diabetic career. Metformin being the first choice after lifestyle. Recommendation number 2, if they're not achieving targets within 3 months or so, metformin is the drug of first choice if lifestyle is not working. If the A1C is quite high from the get-go, you can use metformin in combination with something to get the blood sugars down more effectively. Use insulin if there's catabolic features. Don't sit on high blood sugars for too long. Don't fall to therapeutic inertia. Make changes within just 6 months. Utilize the drug of second choice based on cardiovascular disease. We talked about that, empagliflozin, canagliflozin, and liraglutide. And if you don't have cardiovascular disease, you have 3 choices: DPP-4, GLP-1, SGLT2 inhibitor. If insulin is to be added to somebody with type 2 diabetes, generally speaking, using a basal insulin approach in concert with oral agents during the day, sort of a standard approach. If they need bolus insulin, if you get away with using the basal plus approach, with using basal insulin once daily and a bolus insulin prior to the major meal, that sort of simplifies things and helps to alleviate weight gain and hypoglycemia risk. And, of course, if patients develop hypoglycemia on NPH insulin, then using a long-acting insulin analog is the approach of choice. Pharmacare will cover Lantus, insulin glargine U100, and Lemire insulin under special authority if NPH causes nocturnal hypoglycemia. We don't have that coverage currently for Toujeo, which is glargine insulin U300, or Didec, Tresiba insulin. Those are possibilities. If patients develop hypoglycemia, even while using Lantus, then switching to either Toujeo or Tresiba would be indicated. we talked about that. So the third dimension is the whole concept of SADMANs, meaning that there are certain medications that should be held if patients are ill and have a reduced oral intake, essentially are throwing up or have diarrhea, and metformin and sulfonylureas are part of that, as well as the new class, the SGLT2 inhibitors. The concern about Invoquina, Jardiance, and Forxiga is that there's very small risk for euglycemic diabetic ketoacidosis, and thus if your patient has major surgery or illness or reduced oral intake with flu-like symptoms, that the SGLT2 inhibitor should be on hold to reduce the risk of diabetic ketoacidosis. And I think that's it for the type 2 recommendations. Why don't we open it for questions before we go to the type 1?
Thank you. So just a reminder for those that may have questions, you can now push #6 to unmute your line.
Have you seen euglycemic diabetic ketoacidosis from an SGLT2 inhibitor?
Kamloops, yes, we've seen it on an inpatient basis.
Yeah. I was asked to comment on the possibility of adding SGLT2 inhibitors to inpatient formularies, and I strongly suggest that that would be inappropriate. So certainly, if patients are in hospital and you're hoping to sort of advance their intensity of therapy, starting a SGLT2 inhibitor while patients are inpatients is generally not a good idea. They need to be patients and medically stable and not acute anymore to reduce that risk. If they were on it before they got into hospital, but clearly most people get into hospital because they're ill, their SGLT2 inhibitor should be discontinued temporarily until they're outpatients and well again. There was an interesting case series from a Canadian anesthesiology journal from earlier this year that had described 3 patients that went in for open heart surgery for CABG, and in all 3 cases, the SGLT2 inhibitor was held 1 to 2 days before surgery, and despite that, all 3 cases had DKA in the post-op recovery room. So there's really no consensus yet on how soon you have to stop these drugs prior to surgery. Nobody really knows. So I think exercising caution is the byword until we know what to do. Questions?
Another question here from Kamloops.
Just thinking about guidelines when they're starting an SGLT2 inhibitor, what they do with their glyburide or their glycoside if they're starting something like that, or with their...
Right. Well, generally speaking, if they're on insulin, I reduce the dose by a certain amount, 20 to 25%, whatever regimen they're on. If they're on a urea, it kind of depends on how high their A1C is to begin with. So if you're adding it and the A1C is sort of in the 8.5% or less range to begin with, I would think about potentially stopping the glyburide and just using the SGLT2 inhibitor in its place for a period of time, reassess the response, and then consider adding back a portion of the sulfonylurea later if need be. If the A1C is really quite high, over 9%, then you're probably safe just carrying on with your usual dose of sulf. So, a little bit of clinical judgment. It kind of depends on the A1C, I would think. But I often cut the dose in half or even stop it altogether for those folks who don't have a super high A1C to begin with. For example, if the A1C wasn't too bad, it was, let's say, 7.8%, but the history of coronary artery disease, and you want to switch them to a drug that will reduce their cardiovascular event rate, and I would substitute the self for the SGLT2 inhibitor as opposed to adding it to it. But again, trial and error.
And if someone has a history of yeast infections, would be inappropriate for an SGLT2 inhibitor, but that's related to those high blood sugars you've had.
Yeah. It's a contraindication. I think the anecdotal evidence is that those that start SGLT2 inhibitors when their sugars are really quite high, so they have a quite high A1C to begin with, have a history of yeast infections. They're the ones that are definitely going to get into trouble. For those, once the blood sugars come down to a good, to an improved range, then the frequency of the yeast infections becomes less. So, once your blood sugars are lower, the glycosuria will be alleviated to a certain extent. So you can kind of predict who's going to have it. It's usually women, and there'll be more often women who have quite sugars to begin with, and reassure them that treatment is a regular yeast infection, so you give them a single dose of fluconazole, and it'll generally get rid of it. And once the sugars are lower constantly, then the likelihood of recurrent yeast infections will abate with time if they respond to the drug. So if they're willing to grin and bear it for a while, it may be worthwhile pursuing. The infections are less often seen in men, and more commonly those who are uncircumcised, interestingly enough.
Also, to ask about metformin, I've heard from some of the physicians that 250 milligrams BID of metformin isn't really worth it.
It's not worth it, right? It's not worth much, put it that way. People are very sensitive to the stuff, and if they're maintaining decent A1Cs with a very low dose, I think that's fine. But if they've got quite high blood sugars and they can't tolerate anything more than 250 BID, then it's probably not doing anything, and I would focus on something else. But I think a minimal effective dose would be 500 milligrams BID, generally speaking.
Just initiating insulin in BC with our coverage.
Yeah.
Are you tending to just get NPH started and get it out of the way so that you can get to the newer insulins? It's just with extended health coverage, sometimes that changes for people. They may lose a job or they retire, and now
right.
They have the coverage, and they've never been on NPH, and now you're on Atlantis or Tueo, and they can't afford it. So I just was wondering what you do when you're...
Well, that's a special circumstance in the sense that, with type 1s newly diagnosed, I put them on a long-acting basal analog at the get-go. But thankfully, when an endocrinologist writes the prescription, it's automatically covered under special authority, so we don't have to worry about that. Grandfathered into that system. For type 2s newly to basal insulin, I'm usually starting NPH anyway, and if they develop nocturnal hypoglycemia on NPH after they've had their diabetes for a number of years, then they would qualify for special authority for Land or Levemir. So I haven't had a problem with it, but not everybody's an endocrinologist and has that. Any power they give us, by the way, we don't really have any other pull any other way. But it's a tricky question. I mean, some people, they lose their job and they don't have the coverage anymore. If it's somebody with type 2 diabetes, they do fine on NPH, actually. So that wouldn't be a huge problem. If they do have bona fide type 1 diabetes, then I really think that they would significantly benefit by sticking with the long-acting basal analogs, and they have to pay for it themselves, and that's the way to go. So yeah, individualize it, I suppose.
Are there physician groups that have any of that? Like, does internal medicine have that ability? I don't think so, but
I don't believe so. No. So moving on to the 5 minutes. This is probably nothing new to this group, actually. The only really of interest here is the fact that we have some new insulins available to us. But basic concepts of insulin therapy for type 1 is the same, recommending either intensive insulin therapy through MDI or insulin pumps is currently the gold standard. We do have some newer insulins available to us, specifically ASP insulin, which is a faster-acting insulin aspart in that first box here. And we've got some new basal insulins as well. We've got Lantus generic or biosimilar, which is the Eli Lilly product Basaglar. We've got concentrated insulin gene U300, which has a flatter profile and a longer half-life. And then the longest-acting insulin with the flattest profile, insulin degludec or Tresiba, both 100 and U200. It's interesting, if you take glargine and you go from U100 to U300, that concentration will alter the pharmacokinetics. With insulin degludec, you go from U100 to U200 concentration. It does not alter the pharmacokinetics, so they act equivalently. Our premixes as before. So the concepts aren't really any different. The I guess major thing is that, of course, now the government has informed that they're covering insulin pumps for all patients with insulin-requiring diabetes. So that's making our lives much more busy. And the thing that I suppose the one thing I will say is that I would have, if I was the only one that was recommending things to government, what I would probably say is, I would say, okay, it's fine to recommend pumps to a wider audience. I would probably say, why don't we cover insulin pump therapies for all ages who are currently having problems with their episodes of severe hypoglycemia or reduced hypoglycemia awareness, and for that group, we will cover the cost of the pump and a real-time glucose sensor. So I think that would have been a more targeted way of addressing this. That would have been my preference. But so now we're opening up pumps for a wider group of people, but not giving them coverage for the CGM, which is only sort of going halfway as far as I'm concerned. But the editorializing a little bit. We know that the benefits of the pump can improve an A1C, actually for those people who have a high A1C despite their best efforts on MDI. That's one of the indications for switching to a pump. Patients generally prefer insulin pump therapy. It affords them greater flexibility. And those who have severe hypoglycemia, it can reduce the risk, especially with the low glucose suspend feature with the Medtronic pump. And the bits of a sensor, GM, will be improving the A1C without in the rate of hypoglycemia and improving quality of life. Recent study with the Dexcom G5 Hypo-D study showing that those people with reduced hypoglycemia awareness or recent severe hypoglycemia, that the real-time CGM reduced hypoglycemia compared to continuing self-monitoring of blood glucose. Ultimately, the sensor-augmented pump can be helpful for those who have trouble with nocturnal hypoglycemia. The sensor picks up the low blood sugar and can turn the pump off to protect people from severe lows. So there are certainly advantages of this. Adjunctive therapies currently, they're not recommending routinely the use of metformin, SGLT2 inhibitors, or GLP-1 receptor agonists. Some small studies showing some benefit, not necessarily long-term benefit. SGLT2 inhibitors with type 1 diabetics increases the risk of DKA. So if you're going to use adjunctive therapy, it's with a caveat and with caution. Big bolus insulin or pumps is recommended as treatment of choice, and rapid-acting analogs and long-acting analogs recommended type 1s ideally, as opposed to intermediate-acting insulins and the old regular and Toronto insulins. And if hypoglycemia is an issue with Lantus or Levemir, then we should be thinking about Toujeo or Tresiba. Not terribly new there. Hypoglycemia with diabetes education, of course. And a lady today that is being considered for insulin pump. She's being considered for the islet cell program in Vancouver. She's 70 years old. She has a 40-year history of type 1 diabetes. She's widowed. She lives alone. She has hypoglycemia unawareness. She lives a mountain just outside of Grand Forks. So clearly high-risk sort of person. She was on Lantus twice a day, so I suggested that she switch to once-a-day Tresiba to reduce the nocturnal hypoglycemia. She's looking into getting coverage through her insurance plan for the Dexcom G5 CGM, as I think that she would benefit from the warnings of impending hypoglycemia in her case, because she lives alone and it doesn't have any warnings from a symptom point of view. Hopefully that may do the trick for her and she can avoid having to do an islet cell transplant. What else say? I think none of this is new to you folks. As far as the sensors are concerned, if you're going that way, clearly the studies have shown that the sensor is only of benefit if it's used most of the time. So 70 to 80% of the time, they need to be wearing a sensor in order to derive benefit from it. And we're on time. Let's open it up.
All right, Dr. Phillips, again, just if you'd like to ask a question or offer comment, #6 to unmute your line.
Phillips, it's still common in the Kootenai boundary. I had a couple of questions. One was on the early introductions of insulin therapy along with nutrition, and then discontinuation of that. What the benefits? I think it was the study that Dr. Gerstein did, and I just wondered if we have any further information on that. And
yeah, I read that paper and I was a bit surprised by it because you know, very, very similar studies were done 10 years ago that basically I thought had already answered the question. Doing that, you know, occasionally, and I still do it occasionally. So you had somebody with, you know, who you think has type 2 diabetes, but they're, you know, got very, very high blood sugars. They might even have an element of DKA. You know, some of the First Nations group will have sort of ketosis-prone type 2 diabetes. And if, you know, if they've got A1Cs of 14%, something ridiculous like that, I think it's perfectly reasonable to put them on basal bolus insulin and metformin from the get-go for a period of 6 to 12 weeks, normalize the blood sugars, follow them closely, and after a period of 12 weeks, stop insulin, or at least stop the bolus insulin, plus or minus the basal, continue on with the metformin, and the idea is that it would potentially eliminate the, quote, glucose toxicity, unquote, and improve their beta cell function and allow them to maintain good glucose for the, you know, for a number of months or even a year or two after that, just on metformin and basal insulin. So I think it's a concept that has been shown to be helpful, and you know, many years ago, but it's been rediscovered as a I agree with that.
you. The second question was just if, and perhaps this is another lunch and learn, but the information that was released, I think it was a pretty small study on BCG being in type 1 diabetes and seeing insulin production increase.
Right. That paper is sitting on my coffee table right now.
Okay.
In fact, it's for download. You don't have to have a subscription to the Nature group. It's a vaccine journal, obscure vaccine journal, but I would recommend people look at it. But this, this particular study has been going on for a number of years. I think out in Boston, and I don't pretend to understand, what the mechanism of this BCG tuberculosis vaccination is, but evidently long-standing type 1 diabetics who received this had an improvement in their A1C and a reduction in their insulin requirements through some sort of epigenetic changes that they were able to document on, involving their T cells or something. I will plead ignorance, but I promise I'll read the paper.
Oh yeah, it was very interesting. I forget, 10 years ago or something. Maybe somebody on the call will remember. There was a good session at one of the Diabetes Canada professional conferences on sort of debate on whether there's insulin cell destruction or is it just apoptosis. And that just made me wonder in light of the BCG information.
Yeah, I think we have better ways of identifying cell function and persistence. And I think thinking that for most people with type 1 diabetes, that there is some persistent beta cell mass that even in long-standing type 1s, and there's some way of getting them to regenerate or at least not completely fall out. It might be of benefit. So.
Thank you very much.
You're welcome.
Any other questions? Again, #6 to unmute your line if you'd like. Okay, well, not hearing it coming onto the line. We've got a few minutes left. If there's any final comments you'd like to offer, Dr. Phillips, and then we can adjourn for the day. Okay, well, Dr. Phillips, assuming you don't have any closing remarks, just a reminder, we are recording these sessions, and once available and posted, we will send an email out to all of you as attendees, so you can access them and or refer them to your colleagues who may not have been able to attend. Once again, thank you to our speaker, Dr. Phillips, for offering yet another lunch hour, and same to those of you that chose to spend your time with us here today. So look forward to future Lunch and Learns, and have a great rest of the afternoon, everyone. Thank you.
Bye-bye.
Bye, everyone. Bye.